Josh Lampert from Miami, Florida, and today we're talking about the hemoglobin molecule and specifically smoking around the time of surgery. So no plastic surgeon wants their patient to smoke before surgery. We all want you to stop at least a month before surgery. And one of the big reasons comes at the level of chemistry. So the hemoglobin molecule binds oxygen and helps our red blood cells take oxygen to healing tissues and take carbon dioxide and get it out of the body. So that's really the main role of hemoglobin that we understand in our body. But one of the problems with smoking anything, whether it's marijuana smoke or cigarette smoke, is carbon monoxide that is in any smoke, and even in a fire if you were exposed to that carbon monoxide molecule binds irreversibly to the hemoglobin molecule, and it blocks the ability of the hemoglobin molecule to deliver oxygen to healing tissue. It basically knocks the hemoglobin molecule out of commission, which is why we hate smoking before surgery. And it takes, honestly, probably 3 months to recycle the red blood cells and the hemoglobin. So if you're smoking 3 months before surgery, it can impair and affect your surgery for sure. But studies have shown if you stop smoking 1 month before surgery, you get a little bit closer to normal wound healing. So that's why we usually say at least a month, okay? So let's look at this in a little more easier diagram than this molecule. Okay, so with this diagram, let's focus on the top first, just showing normal breast anatomy. We'll use breast as an example. Any surgery has a risk of complications with smoking, specifically breast. What are the risks? Well, capsular contracture if you have breast implants. Studies have shown significantly higher rates of capsular contracture in patients who smoke. But the one that we're all afraid of, that's in every consent form from the American Society of Plastic Surgery, is a patient could lose a nipple with breast surgery. It's a higher risk in patients who've had multiple breast surgeries, and it's a higher risk when you're doing a lift and placing a breast implant. Knock on wood, to date, I've never lost a nipple, but it's something we're always worried, we're always concerned about, especially if the patient's had a lot of surgery before, and especially if the patient has a smoking history. I personally will not perform a breast lift on a patient who hasn't quit smoking and using nicotine products for at least a month prior to surgery. And one of the reasons is the nipple has blood supply that we know about, and that blood supply is really important to keep that nipple alive. But with surgery, especially if they've had multiple breast surgeries in the past, a lot of that blood supply to the nipple has been cut. So we can't rely on as profuse of a blood supply. And sometimes there's just a couple larger of these major vessels that are keeping this nipple alive if the patient's had prior breast reduction, prior breast implants, multiple prior breast surgeries, or breast reconstruction. So one of the problems with specifically nicotine, nicotine is the worst thing to smoke, probably crack is the worst one, but nicotine is really bad because it causes vasoconstriction. It causes these arteries to shrink down in size. So there's not as much of a pressure head and not as much blood flow to the area that we want to heal. So that's one of the problems with nicotine specifically. But a lot of my patients, they smoke marijuana, and they ask me, is it okay if I smoke marijuana? Well, marijuana doesn't have nicotine, so it doesn't cause that vasoconstriction, which is great. But I personally don't like the smoke because smoke has carbon monoxide in it, okay? Carbon monoxide binds irreversibly to the hemoglobin molecule, and it makes our red blood cell really unhappy, okay? If we look at our happy red blood cell, he just got back from the gym, he's working out, he's doing cardio, he can get rid of the carbon dioxide, right? We breathe in oxygen, we breathe out carbon dioxide. And then he can grab oxygen, and that's his job. He's grabbing, he's juggling, no problem. He's happy, he can do it, piece of cake. His hemoglobin is strong. He doesn't have carbon monoxide, he doesn't have nicotine, he doesn't have any of those problems. And this is the guy we want when the wound is healing. We don't want to have any problems with blood supply to the wound. We don't want bad scars, we don't want capsular contracture, we don't want to lose skin or have skin die, okay? Because that leads to bad scarring. So the happy red blood cell really helps us have more reliable results as plastic surgeons. The unhappy red blood cell, he's blue, he can't bind oxygen as well because his hemoglobin is full of carbon monoxide. So he's got the carbon monoxide, heavy weight anchoring down. He can't juggle those molecules that are needed not only for survival, but also for wound healing. So a patient that has a lot of carbon monoxide saturating their hemoglobin molecules, they're exposed to smoke, whether it's marijuana smoke or cigarette smoke, that patient is not going to heal as well because of that unhappy red blood cell, which is really important to deliver life-giving oxygen to the healing tissues. A lot of patients ask me, what about edibles? What about the tincture? A lot of patients are on medical marijuana. To be honest, I don't have a really strong opinion on those regarding wound healing. I think the edible forms of marijuana likely do not impact wound healing that much from at least the large evidence-based studies I've looked for. There's no real signs of that. I do have concerns sometimes with the dosing. Patients frequently who smoke marijuana will say that edible marijuana or THC is much more potent and potentially can inebriate them significantly more. I'm always concerned, and we can never allow a patient to come in to sign informed consent or the morning of surgery. Let's face it, if you're high, the anesthesiologist and I will cancel your operation. But the other thing with smoking, speaking of anesthesia, is the anesthesiologists do not like when patients smoke. Those patients cough, they have lower oxygen saturating, they have a higher risk of pneumonia and lung-related complications with surgery. All the risks go up with smokers. And the other thing too with smokers, there's a lot of mucus that has to be suctioned out by the anesthesiologist, which is not only a risk, but also disgusting. So we really want patients to stop smoking for a number of reasons, and the anesthesiologist is probably the only other doctor that wants them to quit smoking more than I do.